Good afternoon, everyone. Thanks, Shweta. So, my topic is on ocular hypertension, the way forward. We all know the definition of OHT. It's IOP more than two standard deviation from the mean of a normal adult population with normal fields and no evidence of optic disc changes. However, studies they differ in the definition of what is normal fields and normal optic disc structure. We need to have a thorough understanding of the evidence based risk factors. There are a lot of questions that come to mind. So, which are the risk factors which play a role in decision whether to treat a given patient with OHT? How do we synthesize a patient's risk factor profile into a recommendation on treatment? And does delaying the treatment of OHT matter? There are several other questions. The OATS study tried to answer most of these. The OATS phase one study, actually, it was a proof of concept, and to know whether medication would delay the progression of OHT, conversion of OHT to POAG. And it was also to determine the major clinical and demographic factors that would predict which patients would develop POAG. Then the OATS phase 2 study was an extension of the OATS 1 study. OATS 1 was over 7.5 years, and this was another 5.5 years. And this was, the patients who were randomized to the treatment group in the OATS 1 were continued the treatment and followed up, and the patients who were randomized to the observation group were started on treatment. That's the OATS 2, and the objectives were to find the cumulative incidence of POAG in the delayed treatment group, and also the subsequent course after diagnosis, whether it's worse in the delayed treatment group. Then there's the third phase of the OATS study. The objectives were to determine the incidence and severity of POAG in the cohort, and also one objective was to find to develop a 20-year predictive model, so which would assess the previous factors as well as identify new risk factors. We all know the results of the OATS 1 study. The ocular hypotensive agents, in fact, reduce the risk of progression of OHT to POAG from 9.5% in the untreated subjects to 4.4% in the treated subjects over the period of 5 years. And they also found out five major risk factors in their prediction model. So, one was the age, the IOP, second IOP, third was the vertical cup disc ratio, fourth the pattern standard deviation, and then the fifth is the CCT. In fact, CCT was considered a strong predictive factor, and the risk was 3.4 four times more risk for progression to POAG when the CCT was less than 555 microns. And the OATS 2 results was that the cumulative proportion of POAG development was 0.22 in the untreated cohort compared to 0.16 in the treated cohort. And they also found that the absolute effect of early treatment in decreasing POAG incidence was greatest for the high risk OHT. This number is very important, number needed to treat. So this means for every patient that is prevented from developing glaucoma, how many patients need to be treated to prevent one person of OHT getting converted into glaucoma. So Cass, the lead investigator, and his colleagues, they stratified into based on the risk into low risk, moderate risk, and high risk. And this number needed to treat was 98 for the low risk group. So 98 patients in OHT have to be treated to prevent one person from developing POAG. So in the moderate risk group, this NNT was 16, and in the high risk, it was 7. These risk calculators actually are a good starting point to help us decide which OHT patients need treatment. So this is based on that five factor predictive model of the OATS study. And to initiate treatment, so when you calculate the risk, this risk based on these five factors, if the 5-year risk was more than 35%, or then 35 or more than 35, then you can consider treatment. An important thing to note is some of the important risk factors like myopia, race, cardiovascular disease, family history of glaucoma, diabetes. So these were not considered as risk factors in the prediction model of OATS. Especially diabetes gave very inconclusive results. So what is the way forward? The approach to management, that is when to treat and when to monitor, would depend. So a good way is to would be based on stratifying them into high risk, moderate risk, and low risk. Majority of the patients fall in the low risk group. So because of so they just I mean so they require just monitoring at less frequent intervals, once in 2 years. So those in the moderate risk group can be monitored at frequent intervals, and treatment is withheld until damage is documented. Whereas in the high risk, you can consider treatment. All these risk stratification is based on the RNFL changes, the intraocular pressure, and the CCT and the vertical cup disc ratio. So, what would be the target IOP once you decide to treat? A reasonable aim would be a 20% reduction. And what treatment to choose would be, you can start off with medication, or even SLT you can consider as a primary treatment, and surgery in the form of TRAB or now MIGS techniques available, you can choose that. So in summary, ultimately the decision whether or not to initiate treatment is the patient's. So this is the most important thing. And there is a continued need for pragmatic RCTs and cost effectiveness studies using realistic everyday data.